Hi, I'm Dr. Rahi Victory, a reproductive endocrinology and fertility specialist, board certified in Canada and the US, and you are watching Fertility Fact or Fiction, our weekly show where we review all the myths and the facts and go over how to make your journey better. We always present a case or an article first, and then we review that so that you can get better educated, and then we answer your questions live. So stay tuned and watch till the end, and we will get your questions answered. Almost always we get through most of them, so hopefully you'll stay with us to hear what the answers to your questions are. And make sure that you acknowledge my dear friend Tarek from Ibrahim Strategies Group, who likes to be acknowledged when you're asking the questions. Tonight's topic?
It's a self-esteem issue.
It's a self-esteem issue? Okay. Are we screen sharing right now?
No, I am.
Should I set that up?
Yeah,
I thought I did.
right. No, you are. You're good.
Oh,
You're
yeah.
good.
Okay. Yeah. So tonight's topic is about whether or not women who do not have, or couples that do not have a lot of embryos, should go ahead and do PGT testing. So let's just talk about that briefly. So many couples will not have a lot of embryos to use. They may have 1, 2, 3, a relatively low number. And in that situation, the question is, should you test the embryos to see if they're genetically normal, or should you not test the embryos to see if they're genetically normal? Because some people say testing them is beneficial, you reduce miscarriages, you increase the chances of success per embryo transfer, while other studies have shown that there may not be so much of a benefit. So the question really is, what's the best approach to this? And the answer is, we don't know for sure. So there have been multiple studies done, small and large. And in some of the studies, they showed that there was a benefit to doing it. But then in the follow-up studies, they showed that there actually was no benefit to doing PGT. But most of these have been in good prognosis patients, especially for the ones that did show a benefit, where these patients had at least 2 or 3 good quality genetically normal embryos. And so the question is, well, that doesn't necessarily apply to everybody. What if we start looking at subpopulations where the patients don't have as many embryos, their ovaries may be weaker, and so on? And so in this particular study, that's exactly what this group looked at. They wanted to know, what is the benefit, if any, of doing PGT in patients who have only 1 to 3 embryos to use? And so they analyzed this as a retrospective study, looking backwards at one pool of data for women that only had 1 to 3 embryos. And they had done PGT testing on them to see if any of them were normal. And then they compared that group to a control group, which they matched. And I'll go through all of those details with you. So the first thing to know, the title is Pre-implantation Genetic Testing for Aneuploidy in Patients with Low Embryo Numbers. And then there's a colon and it says benefit or harm with a question mark. So the first thing to know about this study was done in Toronto, Canada. Yes. And it was done by people that I know well. So Paul T. Chang is the second author, and he was actually my junior resident. And Jim Mariano is the lab director at Trio, which is a great fertility center in Toronto. And Jim is a wonderful guy. I've spoken to him multiple times. He's a wonderful lab director and embryologist. And Robert Casper, who is far and wide acknowledged as being one of the gods of the infertility world. He's an extraordinarily bright man, has numerous patents to his name, and has probably invented more stuff than most people will even dream of in their lifetime. So a great group of people behind this study, definitely people that know what they're doing. I don't know the lead author, but I'm assuming he's either a resident or a new addition at Trio Fertility there. So essentially what they wanted to do in this study, as I mentioned, was look at this question. So how did they do it? They selected the patients that had between 1 to 3 embryos retrospectively. And these were people that had this from their first or second IVF cycle. And they had 1 to 3 blastocyst embryos. And it was done between 2019 and 2020. And they had embryo transfers up till April of 2021. So the study group was 130 patients that underwent PGT-A on all their embryos. And the decision for PGTA was just individual. If the patients wanted it, they did it. And if they didn't want it, they didn't do it. So there's definitely some bias there because these may be people that maybe had gone somewhere else and had had bad outcomes or were worried about something or had a history. So, it could skew the data a little bit. And that's really important to remember. The control group, they matched to 130 patients also who had the same age, BMI, and blastocyst number, but did not use PGTA as part of their protocol. And I've highlighted that all in yellow. I'm not sure if we're still sharing or not there, but so they looked at the cumulative pregnancy and live birth rates, and this included all fresh and frozen embryo transfers during the study period. Now that's something very critical to remember, because if you're doing a PGT cycle, you're not going to have a fresh transfer. You're going to end up with a frozen embryo transfer. So a little bit of this is comparing apples and oranges, because some people got that fresh embryo transfer. Some people were getting a frozen embryo transfer. And not that one's better than the other, but it is different. And so it's kind of hard to compare those two groups exactly. They excluded people that had donor eggs and people that had endometriosis, as well as people that had 2 or more previous miscarriages, because they felt that that was not reflective of the group overall that they wanted. And they eliminated people that had mosaic embryos as well. Excuse me. IVF protocol, pretty standard protocol. Their PGT was a standard PGT technique. There was nothing really exciting there for me to highlight for you. So the results, they had actually started out with 191 cycles where 3 or fewer blastocysts were obtained, or at least biopsied. 34 cases got excluded because they had endometriosis. That makes sense. Or 2 or more miscarriages. A further 27 were excluded because of the fact that they had a mosaic embryo. So this is a little bit of a problem, because those cases could have been valuable, because mosaic embryos actually can be transferred as long as they're not high-level mosaics, and 50% of them will yield a benefit. So again, anytime we're analyzing a study and anytime we're presenting you with data, you really got to dig down into the data and look at the study and make sure it is a good study that you can reference and use based on very solid data. In this case, the first problem is they weren't comparing apples to apples. They were kind of comparing apples to oranges, because there were fresh transfers as well as frozen. And the second problem is they eliminated a bunch of cases because of mosaic embryos. And that's a fair number of cases there, almost 10%. So could that have skewed the data? Yes, it's very possible that it could have, had they included those embryos, which we now know it's okay to transfer. In terms of the study population demographics, you can see it right there. No difference in any of the features, other than that the PGT group actually almost had more eggs present, but it wasn't statistically significant. It was close. As you can see, it's 0.058, has to be less than 0.05 to be significant. So the age, the body mass index, the total number of eggs, the number of 2PN was normal. The mature number of follicles was the same. The total number of blastocysts was the same. And the total number of embryos was actually exactly the same. So that was great. Obviously, in the PGT, they had 90 embryos total that were normal, which was 34% of the total number of embryos that they had. And in the control group, they didn't know because they never tested them, obviously. Okay, so here's the first important fact. Altogether, out of 130 IVF cycles in the PGTA group, there were 26 babies born, compared to the control group, in which there were 56 babies born. So more than double the number of babies were born in the control non-PGTA group compared to the PGTA group, 26 to 56. In addition, there were still another 83 embryos in the control group, but only 13 embryos left in the PGTA group, which could potentially increase the cumulative pregnancy rate, because you now have more babies being born, because the control group could have come back for multiple other transfers. We don't know how many of them would have worked, but that potential is there based on the initial results. So just looking at these various numbers, you can see at the top here, and I'll kind of bring it down for you and expand it there. So the first one is the PGTA for 1 to 3 blastocysts. So 70 cycles had euploid embryos, 60 cycles out of the 130 had no euploid embryos. So almost half of them had no normal embryos. They had to go back and do other cycles. From the first frozen embryo transfer, 36% had a live birth. From the second, 0%, and from the third, 1 out of the whole group had a live birth. When they looked at the other side of this, which was the group that had no PGT, the control, so 45 ended up freezing all of their embryos. 85 had fresh transfers. So this is that first inflection point where you got to realize this is not apples to apples, this is apples to oranges. 28 out of the 85 actually had a live birth, which is very similar to what you got with the first frozen embryo transfer. But then when they had the frozens as well, that now they got another 33% there. So when you took your fresh and you took your first frozen, you cumulatively had quite a high number of pregnancies. From 22 second FETs, almost a quarter of them, a little bit more than a quarter, had a live birth as well. And then 6 had a third FET, and none of those were successful. So also really important to keep in mind. When they looked at it in terms of live birth rate per retrieval, it was 20% in the PGT group, and it was 43% in the control group. So this is a huge number, because getting 43% in a group where they actually don't have a lot of embryos is actually by itself very impressive. And this was highly statistically significantly different, because you can see right here that it is below the 0.05 mark. It's way below that. So that's very, very critical. And essentially, like I said, they've got this 0.2 here and they've got the 0.43 there. So very, very significant numbers. You're looking at over double the rate of live birth when they did not do PGT. Again, keep in mind, we can't make generalized conclusions based on this, but this is concerning data, because we frequently tell our patients you should consider PGT when you don't have a lot of embryos, because it may be impacting the egg quality, and we anticipate you'll have a higher number of abnormal embryos. But what it's not accounting for is the fact that some of these embryos can self-correct, and some of them will be mosaic, and so we need to actually include those in the study. Okay, so we're going to go to the next page. And on this page, they did subgroup analysis based on age. Actually, let me go back for 1 second, sorry. So down here at the bottom, they had the increase in cumulative live birth rate with each embryo transfer. So in the blue at the bottom was the case group, which had the PGTA, and the orange in the upper line there is the group that was the control. So as you can see, the cumulative live birth rate, obviously there were no fresh ones in the PGTA, so that's not, that first part of it there is not really fair to look at. So this part here, you got to ignore, because it would have been 0. So that shouldn't be a continuous line. So at FET1, you've got this kind of almost 20% rate. FET2, you're sort of maintaining it at that rate. And FET3, you're getting that final achievement of hitting the 20%. But when you look at the other group in the control group, it starts at about 22%, and it just keeps going up and up until you get to the second FET. Between the second and the third, there was no change, because they had that 0% in the third FET, but still you're getting a continuous increase with these untested embryos, whereas you're not getting that with the PGT group. It was quite flat across the board. When they broke it down by age groups, they have kind of 2 different versions of it to look at here. It was not statistically significantly different, although it was suggestive or trending towards significance. And so I can highlight that for you here down at the bottom. You can see that the live birth rate was 27% in the PGT for women under 38, and it was 51% in the control group for women under 38. So it was close to significance, 0.054, so definitely suggestive of a trend, but not enough to call statistically significant. When they looked at the women who were over 38 or 38 and older, same kind of findings, 13% in the PGT group, which is really quite low for women that are over 38. That's a very low number of live births. And then in the control group, they had 31%, which is obviously substantially better. Again, it's 0.065 for the p-value, which means it is not statistically significantly different, but it's a trend. Anything under 0.07 we consider a trend. So, and you can see it down here in the graphic. Essentially, it's the same thing. It's just demonstrated to you graphically here. So on the right side, on my left side, I can see that you're looking at the under 38 group, and then on the right side, it's showing the over 38, and they looked at live birth rate per embryo transfer, and then they also looked at live birth rate per retrieval. Live birth rate per embryo transfer was not statistically significantly different between the two, but it was very statistically significantly different based on per retrieval. Now, neither of these were statistically significant in the per retrieval portion when they divided it up into the different ages, as I showed you before, but there are those trends that are there, and that's something important to look at. Oops. So the final portion of this was, again, looking at the blastocysts that they got. I'll show it to you in the graphic form here. So this is kind of important. When you looked at the cumulative live birth rate for women with 1, 2, and 3 viable blastocysts, so they looked at how many blastocysts they had. If you only have 1, there's no difference between PGT and control. If you had 2, the control group did almost 3 times better when they did not have PGT testing compared to the group that did, and that is highly significant. And then again, when you had 3, they showed that it did not make a difference. So this may be so focused and narrowed down that we actually need to decide based on the number of embryos that you produce, whether or not this is something that is valuable for you. So they essentially concluded that, in this subgroup, 3 or less embryos, it may actually be detrimental to do the PGT because it's actually making you do more cycles, inflict more emotional and psychological trauma on the patients, and you actually may end up losing valuable embryos that otherwise could have been transferred and may have resulted in a normal pregnancy, which is the assumption in the control group, because obviously you're going to assume that you're having the same number of abnormal embryos, but maybe some of those abnormal embryos are actually working. And we reviewed that in the David Barad study a while back, where they also said that putting in genetically abnormal embryos, especially the mosaics, can actually yield a normal outcome. So in this particular study, they are strongly advising people to not do PGT if you have fewer embryos, and that it actually increased the time to pregnancy, cost more, and was much more frustrating. So they're saying our data suggests PGTA has limited utility in the subpopulation of women with few embryos and may cause harm. So analyzing this study, am I going to jump on the bandwagon of don't do PGTA in these patients? Not yet, because again, there are some flaws in this study. Apples and apples? No, it's apples and oranges. They're comparing fresh versus purely frozen transfers. And they eliminated the mosaics, which is very problematic because those mosaic embryos have a chance. So I'm not sure I'm there yet, and it certainly begs having a randomized controlled trial, but it is very compelling to consider whether or not this makes sense. And as my amazing lab director, Dr. Khosravi, pointed out to me, there is yet another study which actually supports this one and says that it is not useful in women that don't have a lot of eggs. So is it a fact or a fiction that PGT is detrimental? and not necessary in women with 1 to 3 or fewer blastocysts? The answer is I'm not 100% convinced yet, but it actually looks like there may be a fact that it is detrimental and not of any significant benefit to you. So that's fertility fact or fiction for this week. Thank you for watching. Make sure you click the like and subscribe button to learn about more exciting videos. We have one we're going to be publishing soon called the Top 10 Reasons Your IVF Cycle Failed.